much for the organizing committee. I was told about the talk yesterday, so this is last minute, but inshallah it'll be okay. So today I'm going to talk about evolution of prone lateral surgery and go from simple degenerative cases to all the way to complex deformity. Here are my disclosures. So in terms of objectives of today, we're going to talk about some of the advantages of doing prone lateral, talk about some of the nuances that I've learned. I've done close to 100 prone lateral cases, and some of the lessons that I've learned. I used to be a just XLIF patient physician, but now I've actually moved all my practice to prone lateral, and then go through an evolution of techniques from simple degenerative all the way to complex deformity using prone lateral. So as Dr. Anwar beautifully said, I think some of the advantages of XLIF or lateral surgery is that you don't have to go through the back muscles. So people that are obese, people that have had previous surgery, you don't have to deal with all of that. As he said, you have increased surface for fusion. Some of the disadvantages is that I put on quote here, have to flip over for doing instrumentation. I actually used to do a lot of anterior, like Dr. Dominic showed. And I think another big disadvantage, and we'll show it in the deformity cases, is that you can't combine it with other approaches. So if you want to do a PSO at a lower level, or you want to do something else, then you're going to have to kind of flip back, and we'll show how we can combine it. So one of the things that we know is that just from positioning the patient, we'll get some extra lordosis. As the first speaker told us today, we're just fighting for any types of degrees, right? It's so important. So we know that just from positioning the patient, we get 5 degrees of lordosis. And so those 5 degrees, we're losing it if we put the patient just in a lateral. Other things that have been shown is that when you put the patient prone, the retroperitoneum will fall away from you. This is a study that was done by Pimenta recently. So if you're just in a direct lateral, the retroperitoneum can be close to you, but if you put somebody prone, the retroperitoneum will fall away from you. I do have to say, and I agree with Dr. Anwar, that when you put somebody lateral, the distance will decrease. When you put somebody prone, actually the distance will increase. So that's one disadvantage of the prone lateral. This interesting study that was done by Pimenta's group is that they actually got healthy volunteers to put them in supine, lateral, and prone, and looked at where everything was, where the vessels were, how the psoas was changed, and how the plexus changed. So they found some very interesting things. So when you're in direct lateral, the psoas will actually move more anterior, and that can be problematic. When you put somebody in prone, the psoas will actually move posterior, so that will help you. They had some markers of where the plexus was, and they said that they didn't see any major changes. You do have this considerable increase in lordosis when you put somebody prone, and that's something that we all know about. Another thing is if you extend the ipsilateral thigh, you can actually move the femoral nerve more posterior. So for the people that are expert lateral surgeons, when you dock, you can be more confident that you're not going to get a femoral neuropathy. So they actually showed that you can move the femoral nerve a whole centimeter posterior. So that can be very advantageous to you. So can we combine the advantages of lateral interbody, as Dr. Anwar said, with prone positioning? And I would argue yes. So this is how we do it in our center. So we actually move the thigh pads very caudal, and we really build up that lordosis. So that really helps. Another big advantage is that if you're doing lateral, the setup time can be quite extensive, right? And you can't have a PGY2 do the positioning, right? You have to be there from the very beginning. You have to tape the thigh down and so on. But now, just with moving those thigh pads more caudally, I can have a PGY2, do the draping and so on. This is a paper that was done by the Italian group looking at direct lateral compared to prone lateral. That's what they call the prone XLIF. And they found some very interesting things. So as we would expect, the prone lateral will decrease the amount of time, right? Because you don't have to flip the patient. But one of the disadvantages is that it was very extensive in terms of the fluoroscopy, right? You can imagine that if you're trying to do a prone lateral and the C-arm is in your way, that's very difficult to do. So one of the solutions that we've actually done is using this, what we call fluoroscopy image guidance. So this is a system that was developed by one of my partners, and it's real-time fluoroscopy instrument tracking. You put the fiducials on the C-arm, and there's no fiducials on the patient, and then you put your infrared marker there, and you can see here how it works. So it allows you to see both, if you see on the left side, the lateral and the AP at the same time. And this also allows me to allow the fellow to do more because I can see exactly what they're doing in both directions. And so I can move the C-arm out of my way so it's not in my way while I'm doing the lateral approach when the patient's prone. Now, using this software also, I don't think it'll let me do that, allows me then to put the pedicle screws in. I showed it at the other conference how we can do bilateral pedicle screws at the same time. So I think those are the advantages of the prone lateral. In terms of lessons that I've learned, maybe the hard way, it's really, really important to be orthogonal. Just like direct lateral, it's harder to maintain that orthogonality in your mind while you're prone. So you have to really be careful about that. I think that you can say that gravity is your friend as it relates to the peritoneal contents. It is not your friend in terms of the retractors. So a lot of the lateral retractors are very heavy, and so when you put them there, they will tend to fall more anterior. So you have to be very careful about that. When I used to be a purely XLEF or lateral surgeon, I used to never use shims or anything like that because I could keep my orthogonality. For the prone lateral, I would encourage you to either use a bone screw or a shim in the disc to maintain your position because the gravity will push you, and so you have to be something that's have to be careful about. So we're going to go through some cases, and I'm going to show you how the prone lateral can actually help you as you become more advanced in your abilities to use this. So this is a case, we call it simple degenerative case, 57-year-old retired nurse. She came to me with a left lower extremity radiculopathy. She had a L4-5 cyst there. You can see on flexion extension, she had a spondylolisthesis, but it wasn't mobile. She didn't have a lot of back pain at that time, so what we did for her was a tubular MIS decompression of that cyst. Her radiculopathy got a lot better, but unfortunately her back became worse, and so she was not so happy. You can see here, now her spondylolisthesis seems to be worse. And you can see, thankfully, we got rid of the cyst, so there's no more cyst there. But the fluid in the joint looks to be a little bit more. So we felt that this would be a good candidate for a fusion. Now, for a fusion for this lady, she's a little bit obese. You know, if you want to go posterior, you're going to have to deal with the scarring from the previous surgery that we did and so on. So we felt that this might be a good candidate for a prone lateral. So what we did is we did a prone lateral from the left side. These are her films when we were done. And she's doing very well. So that's a simple degenerative case. The next thing where I think really the prone lateral shines is in the adjacent segment disease, right? Those used to be, as a fellow, the cases that you hated the most, right? You have to go through all the old scar. You don't want to put your bovie, for all the fellows, you know, you don't want to put the bovie through the dura before the attendant comes in. Miserable cases, right? So this is an 82-year-old patient. Actually, I had done his L4 to T1 TLIF 4 years ago, and now had back pain and neurogenic claudication. So you can see here, I think I did a reasonable job at L4 to S1, but now at L2-3 and L3-4, he's got a lot of stenosis. We have reasonable amount of lordosis there, and the CT scan showed that he was well fused. So this patient, you know, in the old days, meaning 3 years ago, you'd have to do an open incision, you'd have to take out all the old instrumentation, you'd have to try to do a TLIF at those levels. You could try to do, you know, a lateral, but to do a lateral at 2 positions and then flip him back to do that. There is some biomechanical evidence that shows that, you know, the strongest construct will be a lateral with bilateral pedicle screws. So what we did for this patient is we put them prone. We do the lateral at L3-4 and L2-3, and then we do a Wiltse incision. and we take out the old rods, we put in the new screws using Wiltse, and then we just put a new rod. This becomes now a percutaneous surgery, right? We lose only 200 cc's. This is the 82-year-old. He went home post-op day 1, right? So I think this is where it really shines. It really helps you take care of these patients in a very percutaneous way. So we actually, and this is our x-rays, I think we did a reasonable job here in terms of his spinal pelvic parameters. So we actually published our series with actually Dr. Pimenta, looking at 24 patients with adjacent segment disease. We see here that a lot of this stuff was done percutaneously, so our blood loss was only 100 cc's. So again, I think this is where the prone lateral really shines. We also found, very interestingly, so when you do a lateral, usually they tell you if you put a 10-degree cage, you're only going to get about 5 degrees of lordosis. We found that actually if you put a 10-degree cage, you're actually going to get 10 degrees of lordosis. And that's most likely because, remember, we said just from positioning, you get that extra 5. So that really was very helpful in that. So for me, for people with adjacent segment disease, the prone lateral really is a game changer and really helped me take care of these patients. So can we do even more complex things with this prone lateral? So this is the MISDIF2 algorithm, which was done by the ISSG, and they've characterized people with deformities as class 1, class 2, class 3, and class 4, depending on the different spinal pelvic parameters. So I'll present a case here, a 65-year-old with debilitating back pain and leg pain. You can see here she's got a spinal pelvic mismatch of about 40 degrees. She has a coronal degrees about 33 degrees. So very difficult case. So what we did is we staged it. So previously this could have been a 3-position surgery, anterior ALIF, probably at 5-1 and 4-5, then do laterals, and then do posterior. So we staged it in 2 stages. First we did the L4 to S1 ALIF, and then we flipped the patient prone, and we did the lateral from L1 to L4. And we started to get some reasonable correction. For all the fellows and stuff, we always show our good cases. This patient actually developed shingles right here, so she stayed in the hospital, unfortunately, for 2 weeks before we could actually do the posterior. But I could tell that we were moving in the right direction. I think I would agree with Dr. Dominic that when you do these lateral approaches, it really makes the derotation maneuvers much easier. So then we took her for a T10 to pelvis with a 2-column osteotomy at L4, where she had some compression as well. And you can see here, we got a beautiful result, right? And she's 2 years out, and she's very, very happy. She still remembers her 3 weeks in the hospital, but she's very happy about what has happened to her. So I think, we looked at between class 2 and class 3, we can actually look at our experience. So we started doing this, and this is a paper that we've just recently submitted. So we're looking at prone laterals for deformity. We had 10 patients here, and you can see, their demographics and so on. In terms of our radiographic outcomes, we can see that we're improving their sagittal SVA, we're improving their lumbar lordosis, and we're actually helping with the Cobb angle. So I think that the prone lateral and these, kind of complex deformities can be very helpful. Now, how about people that come in with class 4 deformities? Those ones are very difficult. Here's one, 60-year-old female, history of 4 previous surgeries, again with debilitating back and leg pain. You can see here she had a fusion now from L3 to S1. You can see at L2, L3, she's very kyphotic. She's got a huge disc there. And you can see in terms of her spinal pelvic parameters, she has a mismatch about 40 degrees. So we're not going to be able to get 40 degrees through any lateral or anything like that. So what we did for this patient, I did this actually with one of my partners, is we put the patient prone, and we did a simultaneous anterior and lateral. So I got into the L2-3 disc, and then my partner did a L2-3 PCO, and then put laminar spreaders and really opened up that space for me. And then I put a huge cage at L2, L3. We got some correction, but it was clearly not enough. But since we're prone, then we can do a PSO at L4 and even get her the most correction. So this really helps you, intraoperatively really increase the amount of correction you can get at that level. But then also, if you have to do more work in terms of osteotomies and so on, you don't have to flip that patient. You're right there. So we did a simultaneous L2-3 PCO with a L2-3 prone lateral with a L4 PSO and a T11 to pelvis fusion. You can see here, we've corrected her very well. She's extremely happy. She's about 6 months out. So I think this case really, shows where you can use the prone lateral to really do, class 4 and very complex deformities. So just to conclude, I think the prone lateral really combines the advantages that Dr. Anwar and Dominic talked about for lateral approaches, but gives you those degrees for lordosis with the prone positioning. I think our use of the radiation reduction really helps us do these surgeries safer and more efficiently. I think prone lateral for adjacent segment disease in my practice has really become a game changer. And I think using the prone lateral for more complex deformities is very promising. Thank you so much.